to us, he said he didn't want an amputation. Could we do anything for him? So we thought we could be more heroic than the original surgeon. So we advised that we'll excise the whole of the distal tibia, one half of the tibia, and put him on a laser arm, do a bone lengthening proximally, and probably able to achieve some union distally. Now if you look at these x-rays, there's good amount of callus formation, or regenerate is calcifying. There's probably good bone formation there. Over a period of time, the infection settled, but within 3 months, he again came back with pouring pus and eventually had an amputation. So a basic principle of treatment, which is not basic to PILON fractures anywhere. Don't be naive, you may not be able to salvage everything that comes your way. Another example of basic principles of PILON fracture. This is a C1 by classification fracture, day 2 of injury. He had an external fixator transarticular as a stage 1 treatment, but fibula was not stabilized. This was done in my hospital by one of my colleagues. 6 months down the line, the fracture had united. Even after the second stage was done, the fibula was not fixed, probably led to a non-reduction of the tibial fracture also. The ankle movements remains good. The patient can squat with difficulty, but he remains a very high candidate for development of ankle arthritis. So another principle is you have to look at the fibular length also when you do the PILON fracture fixation. So, came to the hospital, this patient, for treatment of brachial plexus injury. This was the patient was treated somewhere in Patna. This was the original fracture, CT scan showing the 3 classic fracture fragments with a gap in the articular surface, a lot of comminution. He was treated with earlier in his native place by spanning external fixation and internal fixation at the same time. I was just going on looking at the patient and clicking pictures of his previous x-rays when he objected to it. I could not take the lateral view x-ray. The talus was completely subluxated anteriorly. So again, the principle is buttress the unstable side. It was the anterior part which needed the buttressing, and the bone graft had to be done in the metaphyseal defect. Even if you have a good fixation, you're not putting the plate on the unstable side, you might probably fail. Another example, this patient has come with this situation, probably is very difficult to answer, give a proper answer. Another concept we have discussed repeatedly today is the soft tissue injury. If you have a soft tissue injury like this, which is very common in PILON fractures because of the original injury, and you are thinking about surgery, probably you should avoid it. If the soft tissue injury is like this, as you have discussed, the de-roofing concept is not documented to be beneficial over non-de-roofing, but I do it. You have to dress it with a non-stick dressing and wait till all the blisters have healed and the wrinkles have appeared to go in and fix it definitely. So soft tissue is the boss, you have to respect it, otherwise you'll have it. So you name it, you have it. In PILON fractures, there's severe articular comminution, there is a bad soft tissue injury, skin necrosis and infection, there is a malunion and delayed union and non-union, and there is arthritis and stiffness, and some of these patients, if not treated properly, can land up with amputations. So these are the fractures which demand utmost care. So we're going to quickly run through the objective of this presentation. The mechanism of injury is very important. There are 2 different mechanisms of injury. We have all discussed. Again, this has been already discussed. A low energy fractures need to be differentiated from high energy fractures. Low energy is due to rotation generally. There is less soft tissue injury, probably could be a candidate for an early open reduction internal fixation as compared to a high energy fracture where the talus explodes into the distal tibia because of axial loading, and that explosive energy leads to soft tissue damage, which you have to give time to heal if you want to treat these fractures properly. Again, if the injury happens in dorsiflexion, it's anterior comminution. If it's in neutral, it's probably more of central comminution, and if it is plantar flexion, more posterior comminution can happen. Whatever is the mechanism of injury, it can lead to a wide spectrum of the fracture with a wide spectrum of soft tissue injuries, where you could have a situation where you want to do an early open reduction internal fixation, or you could have a stage where you don't want to delay the definitive surgery. So classifications of PILON fractures started with UD and Elgover, with intra-articular type 1, displaced intra-articular without comminution type 2, and comminuted intra-articular type 3. What we routinely follow is the AOOTA classification, where A, B, and C. It's the C fractures that we are more worried about because they are intra-articular fracture, and with increasing severity of comminution, you classify them into type C3. Each of these fractures can be subclassified depending on the fracture line locations and comminutions. And 27 subtypes have been described, but there is poor inter-observer agreement upon subclassification of type C fractures. These indeed are the challenging fractures. Then, apart from the bone fracture classification, there is a classification of soft tissue injury by Sun and Austin, where grade 0 is no or minimal soft tissue injury, and grade 3 being the most severe skin contusion and crushing. So we are talking about a closed soft tissue injury, not a compound injury. A higher grade fracture generally will have more soft tissue injury, but the reverse may not be true. So once a patient comes to you, how you do decide? So you do a history, you do a clinical examination, and then you do the imaging studies, and these are the two things which will lead you to the decision making about how to treat these fractures. So then, history and clinical examination, again we have discussed that you have to elicit the mechanism of injury, whether it's a high energy or low energy. You have to document the developing soft tissue picture, because on day one, the patient may not have the entire soft tissue picture, because the energy of explosion has been imparted at the time of injury, and this can develop over a period of hours to days into a full-blown soft tissue injury. Comorbidities have to be documented. Diabetes we've discussed again, and nicotine use. There is documentary evidence to prove that smokers have poor healing capacity in fractures and soft tissues. You have to document the circulatory and neurological status. You have to document again the soft tissue swelling, contusion, blisters, and most importantly, you have to do an overall patient assessment, because a high energy fracture, the patient can be having other fractures. You have now examined the patient, done the clinical, taken the history, done the clinical examination, then you take the patient for imagings. So do an AP, mortise and lateral view, you document all of these factors there. You see all of these factors to make the right decision about the treatment options. CT is now the norm in the treatment of PILON fractures, which will define the major fracture planes, the comminutions, and will also help you in preoperative planning. The question is when to do the CT scan. Optimally, the CT is done after you have applied the external fixator for provisional reduction, except in a situation where it is a low energy injury and you are planning to take the patient into surgery without external fixation, obviously, then you can do a CT scan without fixation. Tornado proved with an article in 1996 that if you do a CT scan, then your surgical approach, if you decide it on an X-ray versus you decide on a CT scan, there is a chance of a 64% change in your surgical approach. So then you have done the imaging, you have done the clinical part of it, so then you come to the treatment. The treatment of PILON fractures have evolved over time by initial reports by Rudy and Algover in '68 of immediate internal fixation. Most of his patients were low energy fractures. He gave excellent results with immediate open reduction internal fixations. But on retrospective analysis, people realized that his patients were like skiing injury patients which had rotational injuries, so they gave good results. Though a lot of people emulated him and did an open reduction in the intervening period between the 70s and 80s and landed up with a huge number of complications. Then came a period which was popularized by Tornetta and a lot of other authors stating that external fixator probably should be the mainstay of this treatment. Finally, in 1999, when Sirkin and Sanders published their stage protocol, it probably has become the gold standard in the treatment of PILON fractures. So what are the available options, and what is the algorithm then for the treatment of PILON fractures? So a patient comes to you, I leave the open fractures out because I hate the plastic surgeons. Closed fractures, you have assessed the patient, you have done the clinical assessment, you classified the fracture on the X-ray and CT scan, you have assessed the soft tissues. So if it's a condition where the fracture is truly undisplaced and there is an absolute contraindication for surgery, you may opt for a cast treatment. I don't remember when I did it last. It's a displaced fracture with a complete contraindication to surgery. You can opt for calcaneal pin. I don't remember when I did it last time. It's a displaced fracture with a good soft tissue envelope, low energy fracture. This could be a candidate for an early open reduction internal fixation or a minimally invasive plate osteosynthesis. If it is a displaced fracture with a poor soft tissue envelope and a high energy, which these majority of these patients will fall into this category, then you can go for a stage protocol where in stage 1 you do an open reduction internal fixation of the fibula and do a trans-articular spanning fixation of the tibia, and then after the soft tissues have healed, you go in and do an open reduction internal fixation of the tibia. There could be a category of patients in this where the combination is too bad. You just cannot reconstruct it. There is very limited review of literature at this point in time of primary arthrodesis in PILON fractures. Again, there are people in this audience, especially Dr. Hariharan, who will probably treat all PILON fractures with external fixators and will not recommend open reduction internal fixation. So these are the three main treatment options you will be using for PILON fractures, which means if it is either immediate open reduction or a stage protocol or maybe an X-fix as a definitive form of treatment. This is an example of early open reduction, a low energy fracture, minimal soft tissue injury, operated immediately very soon after the injury. Similar example, fixed with a low profile plate or low profile implant on the medial side, united very well. Some examples of stage protocol. In stage 1, what you have to do an emergent treatment. We have to anticipate future incisions so that you have to fix your fibula by posterior lateral approach. If you plan the tibial incision on the anterolateral lateral side, then there should be an appropriate skin bridge between the two incisions. So what it does is it maintains length, alignment and adduction and gives you time for soft tissue recovery. And then in a second stage, once this has happened, which may take up to 10 days to 2 weeks, then you can do an open reduction with plates and screws. So the concept is to span, scan, plan and execute and then fix. An example of a stage treatment of a compound injury. This patient came to us on day 1 of injury. We did a posterolateral incision for the fibula, did an open reduction internal fixation of the fibula and applied a trans-articular external fixator. On the lateral view, you can see there is a dorsiflexion deformity. We send the patient back suggesting to come back in the outpatients for dressings and then decide about further treatment. He went outside, somebody advised he did not need a second stage, so he never came back to us. We learned from somebody else that he's being treated definitely in the same frame. Another example of a stage protocol, some soft tissue injury, a type C3 probably fracture, treated by a trans-articular spanning fixator and open reduction internal fixation of the fibula. You have to see that the pins of the fixator are far away from your fixation site, from your future incision on the tibia, distal tibia, and you have to apply the pins in the calcaneal tuberosity posteriorly and do a triangular fixation to stabilize the distal tibia and reduce it. So you can see the post-span CT scan showing the three main fracture fragments, the orientation of the fixator, and then finally after the fracture had healed, a definitive, the soft tissue had healed, a definitive open reduction internal fixation which united well with time. So what are the principles of open reductions of PILON fractures? There are 4 basic principles: anatomic, articular reduction and alignment, fibular length restoration, stable internal fixation on the unstable side, which is generally the compression failure side, and bone grafting of the metaphyseal defects. The applied anatomy that we rely on the treatment for the treatment is that there are 3 major fragments in majority of these fractures which have attached soft tissues with them, the ligaments, which when you do the ligamentotexis with the help of external fixator, they will probably reduce the majority of fragments. There is a medial malleolar fragment which is with the deltoid ligament, an anterolateral fragment with the chapter fragment with the anterior tibiofibular, distal tibiofibular ligament, and the posterolateral fragment or the Walkman's fragment which is with the PTFL. The degree of combination will vary obviously with the amount of injury. So what are the common surgical approaches that we use? All of these approaches have been utilized, but the majority of fractures can be fixed by the anteromedial and the anterolateral approach. The decision to use which approach will depend on the location of the fracture lines, the location of combination and the fragments, and obviously consideration for any soft tissues lesions in the skin or other problems. In MIPO, when you do a MIPO, you reduce the fracture by traction or an external fixation. You can reduce the major fragments, but if there is an articular impaction, it probably will have no effect on the articular impaction, and you will have to do either a minimally invasive elevation of the articular fragments, or you have to do a proper open reduction internal fixation. So the anterior medial approach is the workhorse. The incision starts on the lateral side of the tibial crest proximally and goes down across the ankle and turns medially towards the talonavicular joint and the medial malleolus. The superficial dissection has to proceed directly to the bone on the medial side of the tibialis anterior tendon. So ideally the tendon should not be exposed, and you should be lifting a full thickness skin flap from the medial surface of the tibia when you do a deep dissection. You do an arthrotomy and you reduce the fracture from posterior to anterior. Because if you fix the anterior fragments first, you cannot see what is happening posteriorly. Never make a medial direct incision. If there is more comminution on the center of the tibial plafond or a little laterally, then you probably want to modify your anterior medial approach through modification described by Ussel, where the incision is longitudinal up to the joint but curves at the joint towards the medial malleolus. It gives you again a better visualization of the lateral distal tibial metaphysis and lateral articular surface, but the angle could be a problem where there could be a necrosis of the tip of the skin. The anterolateral approach, if the comminution is more on the lateral side and you want to look at the posterior part of the joint, on the CT scan you've seen that you ought to go and enter that part of the joint which is most comminuted, and that is lying laterally and posteriorly, then anterolateral approach is better. The incision is in the line of the fourth ray between the tibia and fibula proximally. Superficial dissection, you have to protect the superficial peroneal nerve. Deep dissection is all lateral to the toe extensors, which is all elevated medially. Arthrotomy, then you have to enter the bone to reduce the fracture, which means you go in posteriorly and start building your fixation from posterior lateral, posterior medial, and then come anterior. So once you have stabilized the fragments and you stabilize them provisionally with K-wires, then you reduce the articular fragments, and then you flip over the anterolateral fragment, the tapered fragment, which has been flipped open earlier to enter into the bone. So what are the implants which we use for fixation? For type C fractures, at least one stem implant is required. Usually a 3.5 millimeter pre-contoured plate is used medially or an anterolaterally. Locking plates have a special role in poor bone quality of osteoporosis, metaphyseal bone defects. If you anticipate prolonged time to union, then locking plates would be a better option. Or in situations where you cannot have an ideal placement of an implant because of soft tissue consideration. The debate then versus the ORIF versus external fixator. So it's an everlasting debate, it's probably never going to end. The proponents of the two schools will show you literature which will support their school of thought. So I can quote an n number of literatures from Marsh, Bone, Pug, and others to state that external fixation has consistently been associated with high rates of pin tract infections, malunions, and non-unions. That is, if you're using external fixation as a definitive role of, a definitive form of treatment. Again, England showed lower clinical scores, a slower return to function, and a higher rate of complications and more infections. But he also stated that patients with worse injuries tend to be treated more commonly with external fixators. So it is very difficult to compare the two treatment options. You might not open a fracture. You generally do an open reduction, but you may not open a fracture which is severely comminuted. So you cannot compare the result of an external fixator with that of an open reduction internal fixation patient. So there are a number of studies in literature which tell you that the fixator results will vary with whether it is a joint spanning external fixator or joint sparing external fixator, or whether it is an articulated fixator to allow for joint movement, and when it is employed with a minimal open reduction of the articular fracture fragments, so results will be different. Now the other school of thought which favors external fixator, there are reports in literature which prove that both are comparable for type C pilon fracture with regard to range of ankle movement, of arthritis scores, chances of development of arthritis, and hindfoot scores. As recently as 2013, Foot and Ankle International, one of the Chinese guys, well, they seem to be taking over the world. We need to do something about it. He said that treatment of type C pilon fractures by external fixator combined with limited open reduction and abdominal fixation is a viable and reliable treatment option for type C. PILON fractures. So, what about future? There could be a role of arthroscopy in assessing articular surface reduction in minimally invasive plate osteosynthesis, and we have to understand more about cartilage injuries, and probably then we can apply those concepts for the treatment of these fractures. What is the role of bone substitutes in metaphyseal defects is still to be documented. So the take-home message is that you have to individualize the treatment, you have to respect the soft tissues, restore anatomic fibular length, restore anatomic tibial articular surface and alignment, bone graft the metaphyseal defect, and achieve stable fixation. Whether you do it with an X-fix or a two-stage open induction internal fixation, the story will still continues. So it's you call it picture abhi baki hai mere dost. Thank you. So, Dr. Karthik wishes to make a comment. Welcome, sir.
Just carrying on with it.
Okay.
We've now got, thank you, Balwinder, for a wonderful talk. We've got Mark Davis to discuss one case with you. Mark.
Thank you. So we've got time for one quick case before lunch, and it's going to be on the theme of ankle fractures and syndesmotic injuries, as we discussed earlier. Yeah, that's great, thank you.
This one?
No. Yeah, that one, thank you. Thanks. Okay. Brilliant. So as you can see, we're talking about a 25-year-old male who he's quite a heavily built chap. He slipped and fell. It was a closed injury. He was extremely swollen. You can see that already on the soft tissue outlines on the x-rays. And the question, you can see the soft tissues here. You can see that we've got clearly a fracture of the medial malleolus and the lateral malleolus. Fairly sort of transverse looking appearance here. Possibly something going on here in the syndesmosis. So the question I'd just like to bring to the floor is, what would be your next step? Does anyone want to volunteer what they would do next? Well, based upon the principles that we talked about earlier, because we have a fracture dislocation in a young man with a great deal of soft tissue swelling, he then went on to have an external fixator applied, and then the soft tissues were allowed to settle. So after that period of the soft tissue settling, he then went to the operating theatre, and he's had the fracture fixed. Can anyone comment on what they see on the internal fixation? The syndesmosis doesn't appear to be very well reduced, is that right? Yeah. So you can imagine the situation. A lateral approach was made to the ankle, and then some form of ratcheted reduction forceps was applied across the ankle, and the syndesmosis was deemed reduced on the image intensification films. But as you quite rightly pointed out, that wasn't the case. So what would you do next if you wanted to be certain of the malreduction? How would you assess this? Well, I would do a CT scan, because ultimately what we're trying to do is look for the reduction of the fibula in the incisura. So at 4 months he was referred to me, and that was exactly what we did. And he had a blocked ankle dorsiflexion, not really because of the syndesmosis screw, but because of the malreduction of the syndesmosis. And as you quite rightly pointed out, there was a malreduction on the x-rays, and this was his CT scan. So you can imagine in theatre that the clamp, the forceps, was applied across here and here, and squeezed and squeezed and squeezed. And on a view that would have possibly been a mortise view, then there would have been overlap of the fibula and the tibia, and the surgeon would have felt comfortable that that was the case, but quite clearly here that this is a malreduction of a syndesmosis. So the decision was then to revise this, and took all the hardware out and used the original approach, and just quite simply was to then dissect into the anterior part of the syndesmosis, and then apply a laminar spreader across between the fibula and the tibia here, just to open it up. And you have to remove all the scar tissue, because over the last few months, that will have filled with scar. So it's never going to reduce unless you actually debride the incisura and create space for your fibula to be reduced. And then once that had been done, it's remarkable how the fibula then sits back where it should have done. And as you can see, I've had to apply a fairly large screw across this. And we then debated earlier about what size screws should we use and whether we should use tight ropes, etc. Well, I needed a big screw, and quite often if you're revising after tight ropes, the drill tracks are really rather large, so you have to use something quite large. And you can see I've used a washer. There is a danger here as you're applying this forecortical fixation, that if you tighten this, you will squeeze the talus out inferiorly, and you can end up actually distracting the ankle joint. So you do have to be careful. And in this instance, I removed the syndesmosis screw 4 months later, and he seems to have done reasonably well. One other thing to say is that with the syndesmosis injuries, it can be very useful to screen the proximal fibula when you're trying to assess for fibular length, because you can get some information about the reduction from the proximal fibular fracture. Sorry? Yes, it's not. This isn't a particularly good lateral view, but yes, it has gone across where I wanted it to go. Yes, it has done the reduction. Sorry? The direction of the original screws or this screw? This screw. What would you not be happy with this, sir?
It has to go from fibula to tibia 30-degree direction.
Yes.
The other way around.
It does look like it's going posterior.
Yeah.
I appreciate that. I appreciate that. I think the main thing is to making sure you actually have manual reduction of your syndesmosis, in fairness. And if you imagine also from here, you need to push that fibula posterior to get it back into seat. So there's no bad thing if that's going to go slightly posterior. Okay, thank you very much indeed.
I think for discussion. Please feel. So in broad terms, I'm going to talk a little bit about the anatomy of the os calcis and why it's an important bone. We'll talk a bit about extra-articular, and really I'm going to focus predominantly on intra-articular fractures of the calcaneus. So here is calcaneus, looking at it from the top. And you'll all know that there are 3 facets, the posterior facet, the middle and the anterior facets, which articulate with the talus. And the middle and anterior facets really are part of the same joint and form a joint with the navicular as well. The posterior facet is the principal area of articulation in terms of its surface area, but you mustn't really forget the anterior middle facets when it comes to managing calcaneal fractures. If you look at os calcis from the lateral side, you can see the crucial angle of Gisane, which is the angle made by the lateral process of the talus, and is a very important part of the management operatively of calcaneal fractures. There's also the anterior process that you can see on the left of your slide there, and the ET is actually the perineal tubercle, and the PT is the calcaneal tubercle on this slide. Looking at it from the medial side, the red ring is around that very important part of the os calcis, the sustentaculum tali. And under that, the G there is the groove for the flexor hallucis longus tendon, which sneaks just underneath that sustentaculum. And that sustentaculum forms such an important part of the articulation of the middle facet and the suspension of the os calcis between its weight-bearing structure underneath and the flexor hallucis holding the calcaneus up underneath the sustentaculum tali. Bowler's angle is extremely important because when you look at all of the studies that have been carried out of calcaneal fractures, of which there have been many, and you look at the outcome after calcaneal fracture management, one of the principal guides as to whether this fracture is going to do well or not is the restoration of Bowler's angle. And Bowler's angle is normally somewhere between 25 and 40 degrees and is made between the most superior part of the posterior aspect of the os calcis here, the highest point of the posterior facet here, and the highest point of the anterior process here, and it's measured as that acute angle there. Chizane's angle, on the other hand, is the angle subtended by the posterior facet anteriorly and the anterior part of the os calcis here, and it's measured as an obtuse angle, and it's about 130 or so degrees. Underneath that is this neutral triangle in the os calcis. That's this area here. And the neutral triangle is important because there's not much in it, as in there's not much bone in the neutral triangle. And you can see that that neutral triangle sits right underneath Chizane's angle, so that the talus acts like a great big axe or a cleaver, bivalving the calcaneus when it gets loaded by the talus itself, driving into that area in which there's not much bone, and carrying the posterior facet into that void. Extra-articular fractures are probably less important than intra-articular fractures and form two main groups. So there's anterior process fractures and fractures of the rest of the os calcis. And anterior process fractures can be those little minor flake fractures that you see close to the cuboid in this area, or can be more major avulsions like this slide shows here. Tuberosity fractures, so fractures of the back of the os calcis, like this here, are a very special case. And I think these are one of the unusual cases of a true foot and ankle emergency, because that process there is under the skin and nothing else. And the forces applied to that by the Achilles tendon and its insertion are massive. And that bit of bone there will find its way out the back of the heel unless you either put that foot into forced equinus urgently or you reduce and fix that fracture. And if that does work its way out the back of the heel, you've got a pressure sore with a bone underneath that will become infected, and that patient will potentially get osteomyelitis and lose their leg. So this is a true foot and ankle emergency, of which I think there are very few. How you fix it is up to you. You can fix it with a percutaneous screw, holding it down, or a little lateral approach and hold it down with a plate, or a tension band wire, which I think is a very valid way of fixing them. So no more about extra-articular fractures. Intra-articular fractures then. So these are common. They're more than half of all tarsal bone fractures, and they're 1 in 50 of all of the fractures that you see in total. So they are genuinely common. They occur predominantly in a fall from height, and about 10% of them have associated fractures, which of course are predominantly lumbar spine fractures, injuries to the knee, femoral shaft fractures. So look for those associated injuries. You've got a patient with an os calcis fracture, almost by definition, they've fallen from a height, and those patients are the same patients who break the lumbar spine. And look at the soft tissues. They're often quite swollen, and think about treating those soft tissues by ice and elevation really early on. In terms of imaging, plain films obviously are mandatory, and CT scans I think are almost mandatory. Certainly if you're going to fix these fractures, they're a very, very important part of the armamentarium. As I'll explain why that's my feeling in a moment. So the lateral view, you're looking for this sort of double shadow of the posterior facet. So here's Chizane's process there on the os calcis, and you can see it's driven the posterior facet down into that neutral space there where there is so little bone. So look for that double density shadow in what might otherwise look like a relatively normal os calcis. They can be quite subtle, and as always, and as we will keep reiterating, the history is absolutely vital. AP view, well, it shows you with the primary fracture line whether it's involved the calcaneocuboid joint, but isn't a particularly useful image. The axial view is a very useful image, principally because it shows you the degree of varus that the os calcis has gone into. And I think there is a bit of a misthought that occurs that these fractures fall into valgus, because when you look at the patients who've been mismanaged or they've done badly, they've got a very prominent lateral wall, and it almost looks like their hindfoot is in valgus. And that the point of contact of the os calcis is almost always in varus. So a banana-shaped os calcis here, and there's the lateral wall with the lateral part of the tuberous lying over on the medial side there. So the axial view is useful, but in all honesty, the axial view is a very useful thing in theatre as well at looking at your fracture fixation. Broden view is the specialist plane film that you might want to take. Broden's view, I'll show you how that's done in a minute, but the angle that Broden's view is made tells you which bit of the posterior facet you're looking at. So the closer your angle of X-ray beam is to the sole of the foot, the more posterior you're looking at the posterior facet. So a 10-degree angle shows you the posterior facet at its back, and a 40-degree angle view shows you the posterior facet anteriorly. So the view's taken like that, so that's a similar position to your AP mortis ankle view, but the angle of the X-ray beam is changed. Rather than just being true front to back, it's angled towards the sole of the foot. So there's a Broden view, and it shows you that fracture plane in the posterior facet, and you can see fragments A and B are separated. And that's a 10-degree view, so that's at the posterior aspect of the posterior facet. The answer to this question is yes. CT scanning has revolutionised the understanding of the fracture anatomy, because prior to this, in all honesty, multiple X-rays just didn't tell you quite how complicated these fractures are, and we weren't really able to elucidate the fracture planes, which are extremely predictable, quite as well as we've been able to subsequent to CT. So it's revolutionised the understanding, but in my hands it's also revolutionised how I treat them. CT scans are carried out with the patient with their hip flexed and their knee flexed and their foot flat on the gantry. That X-ray, that image doesn't really demonstrate that quite as well, but that's the easiest way. So if your imaging department don't seem to be able to take a nice CT series, you want to just get them so they've got a big wedge under the knee. So hip flex, knee flex, foot flat on the gantry, and the beam is just angled straight down towards the sole of the foot. And you end up with nice slices, and that's what you'll see in all the books. On the coronal view, you can see the lateral wall is blown out, and you can very clearly see the sustentacular fragment, and you can see that fracture line through the posterior facet. And we'll talk about classification in a minute, but the classification of those posterior facetal fractures is entirely dependent on a coronal CT scan. The transverse and axial views tell you a little bit more information about the exact fracture lines and where the various fragments are lying. 3D recons, well, I don't think they don't help me at all, but they can be very helpful to show patients just how bad this is, really. They get a good understanding of how multi-fragmented this injury is and how many fracture pieces that you're trying to put back together. I don't think they really help me determine how I'm going to manage them. So in terms of the fracture planes that you get, then you get 3 lines of fracture cleavage. There's a primary fracture line and 2 secondary fracture lines. Now, the fracture mechanism, the fracture line orientation is dependent on the fracture mechanism, so that the force between the heel point at striking determines the angle of the primary fracture line. And the primary fracture line is propagated from a posterior medial direction to an anterolateral direction across the posterior facet of the subtalar joint. So the primary fracture line looks like that. So it's more medial in a varus hindfoot and more valgus in a lateral hindfoot. So the position at the point of impact of your foot determines where that primary fracture line is. So the primary fracture line divides the fracture into 2 main parts, an anteromedial fragment and a posterolateral fragment. An anteromedial fragment carries the sustentaculum and the anterior and middle facets of the subtalar joint, whilst the posterolateral fragment has the Achilles tendon insertion as well as the lateral part of the posterior facet. 2-part fracture, if you've only got a primary fracture line, you've only got a 2-part fracture, and they're usually undisplaced. So the secondary fracture line affects the posterolateral fragment only, and it splits it into a lateral joint fragment and a body fragment, like that. So the secondary fracture line, in this case, has converted this into a central depression type fracture by dividing that posterolateral fragment into 2. Or it can divide it into 2 by creating a tongue type fracture, when the fracture line exits at the posterior aspect of the os calcis. So the coronal fracture line then splits through the sulcus at the base of the sinus tarsi and divides both the posterolateral and the anteromedial fragment, depending on its orientation, like this. So it can turn it into a 4-part fracture, so you end up with an separate anterolateral fragment, which is part of the calcaneocuboid joint. If it exits further across the anterior part, it can divide it into a 5-part fracture line, so that you end up with an anterolateral and an anteromedial fragment. Okay, so that's how the fracture lines work. How do we then classify them? Well, Cotton and Henderson were the first guys to try and classify them, and they came up with that conclusion. So it's about as useful as trying to classify a walnut shell. In other words, they thought it was useless. Subsequently, Essex-Lopresti, as you'll probably all be familiar with in the 50s, classified them into a central joint depression or a tongue-type fracture. So a central depression fracture is like this. So Giussani's process splits that central depression fragment into the body of the os calcis in the manner of that X-ray that I showed you before. Or it turns it into a tongue-type fracture when that exit posteriorly, and you end up with a larger posterior facettal fragment. More recently, Sanders then has classified, and Sanders' classification is different again for two reasons really. One, because it's dependent entirely really on the CT scans, and secondly, because it only really concentrates on the posterior facet. It doesn't talk about anything else in Sanders' classification. So if you only think the posterior facet's important, Sanders is useful, for sure, and the posterior facet is important. So it is a useful classification, but it doesn't tell you the whole story. So Sanders divided the posterior facet into fracture lines A, B, and C, and then divided it into a two-part, a three-part, and a multiple part. So just going through those, so Sanders 1, the fracture line really isn't involved in the posterior facet, or it's only involved in the lateral wall. So like that CT scan shows in that coronal sequence there, you can see that the lateral wall's gone, but there really is very little occurring at the posterior facet. They're not very common, or they're not very common to take to theatre. These are your more common fractures really. So this converts the posterior facet into two pieces, and that can be either an A or a B or a C, depending on whether the fracture line is lateral, which is an A, medial where it's a C, or in between when it's a B. And Sanders 3 then, is that posterior facet then is in three parts, and you've got two fracture lines, either an AB or an AC or a BC. Sanders 4 is just a can of badness really. So lots and lots of bits, posterior facets and lots of fragments. There is no 5 or 6, so 4 is about as bad as you can classify it. And the reason this classification matters is because it helps to guide how you're going to fix them, and it has prognostic significance. So there are other classifications. Debbie Eastwood and Roger Atkins in the UK have attempted to classify as well. This classification system I don't think is in wide use, but it does tell you a little bit about what's happened to the lateral wall, and it is useful to read. It's a very nice pair of papers from about the early 80s, Harry, is that right? Early 80s? Something like that. 90s, okay. And it is useful. It's a paper worth reading, but I don't think you'll ever classify according to them. So I won't bury into that. And then you can, if you fancy it, and you can't sleep very well, read the AO classification, which is unwieldy, and I don't think you can use it. What matters on a classification system, of course, is that it's got to help you in decision-making or prognosticizing or in research, and those are the only three reasons a classification system is ever of any use. And Essex Lopresti certainly tells you if you've got a joint depression or a tongue-type fracture, whether you're going to need to open it or whether you can manage it either closed, by which I mean really through a minimal invasive approach. And Sanders helps you to talk about whether you think this posterior facet is reconstructible or whether really this patient needs a primary fusion, which is probably what you should do if you've got a 4. So the other two classifications I don't think are particularly useful. So can we fix it? Well, the answer to that is possibly. When you're fixing them, the patient's best position, I think, is in a lateral position, a true lateral, and you want to have your X-ray machine well set up at the beginning. So before you prep the patient, have your image intensifier or your X-ray machine there so that you can really make sure that you can get a proper lateral view and a proper AP and a proper axial view. And do that before you start draping and prepping, because you're going to need to use those images during your fixation. So what about closed reduction? Well, as I intimated, I think these are best carried out when you've got a tongue-type fracture where the tongue is the whole posterior facet. And then you can do an Essex Lopresti manoeuvre where you elevate that and then fix it with some screws. If you want to do an open approach, I would recommend that you use the Atkins approach, which is what we would use in the UK. I think that's what most people use, where you lift a large flap containing the sural nerve and its branches and the perineal tendons and all of the soft tissue really, and it's not a flap where you create layers, it's a single layered flap, and you go straight down to bone and extend that incision, staying on bone all the way. As you lift that flap up, it's easy to lift up in the flap some of the lateral wall fragments, which you don't really want to do. So just take your time, be careful. While I'm looking at this image, I should be reminded to talk about timing. So we sort of talked a bit about timing and blisters. Calcaneal fracture management involves very careful timing. You don't need, these are not unstable fractures by and large, and if it's a closed injury, it doesn't need to be fixed day one. If you can fix it day one, and I literally mean within a few hours of the injury, I think that's very safe, and if you get that chance, go for it. If you're seeing these fractures day 2 or 3, which is when most of us see them, please don't go in day 2 or 3 if there's any evidence of soft tissue swelling on the lateral side that is truly soft tissue swelling. One of the problems is you can sit and watch these fractures for weeks, because some of that swelling is the lateral wall that's been blown out. And as Harry said before, some of the swelling is hematoma. But you don't want to go into these fractures too early, or your wound will break down and you will have made that patient significantly worse. I don't think I'll bury into that too much. You need to reduce them. There's a technique for reducing them, which involves the use of levers and careful reduction, understanding each of the fracture fragments that you have, understanding your techniques of reducing them. So you want to be using levers and hooks to position each fracture fragment back. And then once you've reduced it, and you might want to temporarily hold it with wires and get your x-rays to make sure that you've got good reduction, you then need to stabilize it with probably with a plate and some screws, or with some screws. Most of us would use a laterally placed plate, and there are lots of special plates made for this, or you can contour recon plates, or something that's low profile. If you've got very soft bone, I think a locking plate here is an extremely helpful thing. But there are lots of Heath Robinson ways of making plates that will fit around this fracture, but it'll only work if you've reduced it well. So should we fix it? Why should we fix it? Well, the subtalar joint is deranged, the biomechanics are wrong, there are syndromes you can get from the front, you can get fibular impingement, the heel pad is painful, they find it difficult to fit shoes afterwards, and the ankle joint gets involved as well, because the posterior facet of the talus disappears into the os calcis, so that declination angle that you normally have of the talus looking down the foot, not in line with the calcaneus, but goes wrong, and the talus and the calcaneus become parallel structures on the lateral view, so that in effect the ankle is dorsiflexed even when the foot is flat to the ground, and so they get anterior ankle impingement. So not only is the posterior facet gone, not only is the anterior aspect of the os calcis gone at the calcaneocuboid joint, but the ankle's gone too. So the outcome of these fractures, if they're displaced and mismanaged, is poor. So high energy fractures these often are, so the subtalar joint becomes depressed and deranged, cartilage is almost always damaged to some extent, and you really want to try to get the posterior facet reduced to within a few millimeters. The hindfoot biomechanics change because the body fragment moves in relation to the talus in that manner, and the tender Achilles insertion has moved dorsally too. So you end up with an abnormal heel strike because the mechanics of the hindfoot mechanism have gone wrong. And your heel strike can be medial, in which case the body fragment is driven into varus, and the foot adopts a supinated cavo-varus attitude, from which the patient finds it very, very difficult to recover, and they're very, very stiff. And the first ray is then off the ground, and so the whole mechanics of the way in which the foot is hitting the ground and functioning becomes deranged. Or the heel strike can become lateral with a valgus heel, in which case you've got medial pain because tib post is trying to pull that foot into a more neutral position all the time, and the lateral aspect of the fragments impinges in the fibula and causes pain. The heel becomes shortened and broadened, and the heel attachment of the os calcis becomes elevated, so they lose plantar flexion power. So a short, wide heel like that. Fibular impingement is a really bad thing to happen because it hurts a great deal and is very difficult to recover from, because if you just resect the lateral wall because you think that's what's impinging, then the hindfoot drifts even further into valgus. So if you've got subfibular or a perineal tendon impingement, you can't just chop out the lateral wall and think you'll make them better, because that won't work. The lateral wall bulging isn't necessarily an indication to undertake internal fixation, but it represents those poor biomechanics. I won't talk about anterior calcaneal syndromes, short of saying that there are ligaments attached to the anterior part, and if their anterior part's not in the right place, you can get impingement pain. If there are fragments that have drifted down into the heel fat pad and prominent bone on the sole of the foot, that's a source of a great deal of pain. The heel fat pad has already been injured once by a rapid deceleration onto it, and the fat pad doesn't take that well, and those specialized cells that exist in the fat pad become terminally damaged. But if you've got bone that's prominent in the foot, that causes pain as well as that. So the objective of open reduction in internal fixation is to restore the hindfoot biomechanics, to reduce the anterior calcaneus so that you unblock the subtalar joint, to reduce that lateral subfibular impingement so that you can allow this patient, hopefully once the wound has shown some early evidence of healing, to get this subtalar joint and ankle joint moving. And there are lots of different ways of doing that, but CT scanning has really helped us understand the fracture anatomy and to plan what we're going to do. So I guess the question is, surely all of them really should be internally fixed, because that's what we fix. We fix every other intra-articular displaced fracture. Well, so why is there a controversy? What evidence do we have that we really should fix them? Well, there's been multiple attempts to demonstrate that fixation of os calcis fractures leads to a better outcome, and in summary, we haven't managed to demonstrate that. Lots and lots of studies have been done. We know that fixation is associated with a high rate of serious complications. What we also know, because Sanders has demonstrated 20 years ago, that the more you do, and if you do them well and you do more, you get better at it. This isn't the sort of case to take on and to fix if you're only doing 1 or 2 of these a year. Buckley's study, which is widely referenced, was a poor study in all honesty, although it was a valiant effort. He should be congratulated on carrying out a very good effort at a randomised trial, but there were so many confounding variables here that over the years since this was first published, there's been a number of subsequent publications that have poured perhaps some cold water on his initial conclusions. Although he had 6 surgeons in 4 centres with more than 500 patients randomised, 60% of those were done by one individual surgeon in one individual place. So it's not really perhaps the all singing and dancing multi-centre randomised trial that we thought it was going to be. He found that the better you reduced them, the better they did. He found that patients who are litigating as a result of their injury did worse. Well, we would expect that. He found that bolus angle was prognostic, which we already knew, and that wound complications were a significant problem. He also found that you've got a 5-fold increase in requiring a subtalar arthrodesis if you treat these patients non-operatively. And I would say that that's, in its own right, is a very significant thing, because a subtalar arthrodesis in a non-operatively managed os calcis is a very difficult operation to get to work. It's very difficult to restore those biomechanics that have gone so wrong down the track if your os calcis is already the wrong shape. Lots of studies now looking at percutaneous fixation. I'm not entirely convinced that this isn't perhaps a slightly fashionable approach. We haven't got any very good prospective randomised studies of percutaneous versus open fixation, because most people who fix them percutaneously are experts at that, and most people who fix them open are experts at that, and it's very difficult to start to change your technique. So should we fix it? Well, my philosophy is yes, we should, but we need to be very careful that we have very limited aims and a very sensible level of expectation. The take-home messages are that if you want to fix os calcis fractures and you think that that's the right thing to do, go and learn to do it very well in the hands of someone who does it very well and get properly supervised at doing it, not just from the fracture fixation but the soft tissue management as well, because it's the soft tissues that if they go wrong will lead you to have a very, very poor outcome. Investigate them carefully, please respect the soft tissues and fix them very carefully. Thank you.
So, excellent talk. May I call upon Davis to talk on to Talus fractures?
Thank you. Just to continue on the fractures to the hindfoot, carry on also a little bit on some of the themes that we picked up earlier, and again, I'll make no apologies for re-emphasising some of the main aspects of what we're talking about. So we're going to talk a bit about the history of talus fractures, some anatomical considerations. The blood supply, as we all appreciate, is something that we need to respect. The mechanism of injury is important to note. There are classification systems, a bit about management, approaches and fixation techniques we covered a bit about earlier, and complications. And talus fractures clearly is an enormous topic on its own and occupies complete book chapters on its own. So we only have 20 minutes to cover quite a wide range of things, including acute osteochondral fracture, lateral process fractures, a bit about the dislocations and extrusions, neck fractures, body fractures, and head fractures. Some key historical points. Many people have described talus fractures in the literature, and depending on the language in which they're written in, they've been described for many, many years. In the UK literature, two of our famous historical names, Astley Cooper and James Syme, both discussed talus fractures in the 19th century. And then with the advent of aviation, the Royal Air Force paper from 1919 classified or certainly observed these fractures occurring in the tail and neck with the use of a rudder bar and a crash landing. To my mind, one of the key papers was in 1952 by Coulthard, and it's well worth the read. I'd recommend you all to try and download it and read it, because his paper entitled Aviators as Stragglers is still the largest series of talus fractures as a whole that's in the literature. And he reviewed the RAF experience from World War II of 228 cases. And then another key set of papers were written in 1970. Hawkins classified neck fractures, which I think is a seminal paper, and one of the best anatomical studies about the blood supply was published by Mulfinger and Troetta. And then this paper in 2011 perhaps is something you may be less familiar with, but this is an MR angiography study to further look at the contributions of those blood vessels to the blood supply of the talus. So it's a frustrum, so it's a truncated cone. It's an intercalated segment, 60% of which is covered by articular cartilage. And it has no muscle or tendon attachments, and that's a detriment to its blood supply. So Mulfinger and Troetta in 1970 used plastinated dissections to work out in only a small number of cadaveric specimens the contribution of the various vessels to the blood supply of the talus. Then this MRA study in 2011, which was published in Foot and Ankle International, managed to quantify, using MRA and again plastinated dissection, that these were the relative contributions from the various arteries around the foot and ankle. So the 17% of it, so a small fraction of that blood comes from the peroneal artery. About a third of it comes from the anterior tibial artery, but really the major contributor is the posterior tibial artery. And throughout all of this, it's about anastomoses between these three vessels that are the key. So this schematic here shows you exactly what I mean. So here's the dorsalis pedis coming off the anterior tibial artery, and that contributes here to the talus. And when you're just dissecting dorsally, it's important to try and respect that, or at least be aware of that may still have an important component to your fracture configuration with your dissection, to try and preserve that as much as you can. Then the artery of the tarsal sinus here, which comes off the posterior tibial artery. And then on the medial view here, these are the vessels that come through the deep deltoid structure. That artery then goes in through the sinus tarsi, and here that comes off the posterior tibial. Here's the contribution here through to the dorsal part of the talar neck. This is the key inferior view, showing the rich anastomosis that goes through the tarsal sinus and the artery of the tarsal sinus, with both the medial and lateral components. Another bit of structural anatomy which I think is worthwhile remembering is that in order to maintain the column balance between the lateral and the medial column, it's important that the talus, particularly the talar neck, is fixed to maintain the length of either side of the neck, because this will have a contributory factor in terms of malunion of this angle here subtended called B. And that's basically a talar calcaneal angle taken from the AP plane. And you can see if you draw a line along the axis of the talus and a line along the axis of the calcaneus, B is the angle that's subtended in between. Now, if B is elongated, or made larger, sorry, then that will be a resultant planar valgus deformity that you could create. And similarly, if you diminish B, then you run the risk of creating a cave of varus deformity. And these are really important when thinking about trying to do your reconstructions. So if there is comminution on the medial aspect of the talus, that could have a real bearing on the orientation of the axis of the talus. So mechanisms of injury, these are high energy injuries. Talar neck fractures are caused by a severe dorsiflexion force with the application of supination, and that seems to be replicated in many studies. Talar body fractures are often associated with talar neck fractures, and quite often some of the original papers that were written about the subject do have a combination of the two. There are only a handful of papers that deal with the talar body on its own. But the talar body fractures often have an axial force applied too, and that applies some shearing through the articular surfaces, and you can get different shear fracture lines depending on whether they're in the sagittal, coronal or horizontal plane, and they have different bearings in terms of outcome. In terms of osteochondral injuries, inversion injuries seems to be the most common, but you can get them with eversion injuries. Lateral process fractures, there's a great paper by Valdrabano which describes them in snowboarders, and that's tended to be an inversion and dorsiflexion force applied through the foot, and they tend to be slightly lower energy injuries, although the caveat is that lateral process fractures can often be associated with a dislocation of the ankle or subtalar joint. So these osteochondral injuries only account for about 1% of talar fractures, and we'll talk a little bit about lateral process fractures as well in terms of lower energy injuries. So again, this is one of the reasons why it was quite good to go back and have a look through Coulthardt's paper, because in 1952, with the very poor images that they had at those times, a significant proportion of those talar fractures were this. And he clearly noted that the fracture fragment was upside down, and it was difficult therefore to manipulate, and he advocated excision. Now, maybe people in the